Good afternoon and welcome to COVID-19, What You Need to Know, presented today by Dr. Margaret Fisher. Dr. Fisher is Medical Director of the Unterberg Children's Hospital at Monmouth Medical Center and Chair of the Department of Pediatrics at Monmouth Medical Center. And fortunately for us, a long-standing member of the New Jersey chapter of the American Academy of Pediatrics. Before starting, a few housekeeping items. First of all attendees will be muted throughout the entire webinar. Today's webinar will last approximately 45 minutes, followed by a 15-minute or so Q&A. To submit a question, please enter it in the Q&A box on the webinar control panel located at either the top or the bottom of your screen. Any questions remaining unanswered at the end of the webinar will be compiled and the answers provided to participants as soon as possible. Today's webinar is being recorded and will be made available on the NJAAP website by 2 p.m. today. To find it, you can go to our homepage and click on the COVID-19 link. Now, without any further delay, it is my pleasure to turn the webinar over to Dr. Fisher.
Thank you, Michael. And I really want to thank Michael and the New Jersey AAP team for making this webinar possible. It certainly is a topic that's occupying all of us and raising a lot more questions than answers. So let me start with my disclaimer. Much of the information you're going to hear will be out of date probably before it's even posted, and certainly out of date within days. These two websites from the Centers for Disease Control and Prevention and the World Health Organization update their websites literally every single day and provide you with the information that you need. You'll see some other websites as we go through. The Red Book of the American Academy of Pediatrics has a special online chapter about COVID-19, and it's also updated very frequently. And finally, the New Jersey Department of Health is an important website to know about and to use when you're thinking about exactly what to do here in New Jersey. So that's my disclaimer. My disclosures, I have no financial disclosures. I will be mentioning one experimental drug. So what are these coronaviruses? Well, they're actually named because you may be able to see the spokes here around the virus, and that makes it sort of look like a crown. And the Latin word for crown is corona. So they are actually named after the Latin for crown, not the beer. There have been lots of coronaviruses identified. The 4 viruses listed here have been circulating and been known about, I'm not sure how long they've been circulated, but they've been known about since the 60s, since the 1960s. So these have worldwide circulation. Primarily, they're causing the common cold, but disease can be more severe in neonates, particularly preterm neonates. These infections are more common in children than adults, and you'll see that's very different than the novel coronaviruses. These viruses cause winter outbreaks and early spring outbreaks, and it's about every 2 to 4 years that they circulate and tend to cause these outbreaks. The coronaviruses naturally live in bats, and they are the natural reservoir, and there are literally hundreds of strains of coronaviruses within the bat population, within bats. And it turns out that these bat viruses can kind of merge with viruses of other mammals, and they can create a novel coronavirus, which then gets transmitted person to person. There's even some suggestion that the bat coronaviruses may jump or spread to people directly without an intermediary. So we're going to just mention these other coronaviruses, novel coronaviruses. The first one described was severe acute respiratory syndrome, or SARS, and this was a novel strain between bats and civets. And I didn't know much about civets until today. It turns out that civets are an endangered species. They are sold in marketplaces in Asia, and it is thought that that's where many of these novel viruses emerge, from these outdoor markets where there's interchange of the bats and the other mammals. So it turns out the reason palm civets are so endangered is that in Indonesia, they are used to make a type of coffee. So what happens is the palm civets eat the cherry coffee, the coffee cherries, which are the buds of the coffee beans, and then they partially digest it. And the people in Indonesia then collect the civet stool and use that to make what's considered one of the most expensive coffees in the entire world, and that is Kopi Luwak. So that's, or some people call it civet coffee. So if you ever have the opportunity to drink that, remember that you are drinking something that's gone through the palm civet stool. Might turn me off a bit. So this outbreak started in Asia in 2003, and it spread to more than 24 countries. There were an estimated 8,098 cases, 774 deaths, which is a fatality rate of 9.6%. It's important to remember that less than 5% of the cases of SARS occurred in children. And there was, in fact, only one case report of transmission of SARS virus from a child to an adult. There were only 8 cases in the United States, and this has been eliminated globally. There have been no cases reported since 2004. Now we come to Middle East respiratory syndrome, or MERS. This outbreak started in the Middle East in 2012, and this is a novel strain where it's, again, always the bats, but this time the mammal is the camel. So bats and camels get together, the viruses of the bats and the camels get together, the genetic material exchanges, and then you end up with a virus that can be transmitted from person to person. For MERS, all of the cases have been linked to the Arabian Peninsula, so it's mainly been travelers to those areas, and in most cases there is direct contact with the camels, but there is some person-to-person spread. So there are about 2,400 cases, 850 deaths, which gives you a tremendous fatality rate of 34%. And remember, it's not really in the best interest of the viruses to kill you, because people who are dead can't cough, can't transmit the disease. So in fact, the higher the fatality rate, the less likely it is to cause huge outbreaks. For MERS, there were few, if any, cases in children, and there were only 2 cases within the United States. Now that we get to COVID-19, which is the name for the novel coronavirus which appeared in 2019. This is a novel strain of bats and probably the pangolin. The pangolin is a spiny anteater, and the reason the pangolin is endangered is that the meat of the pangolin is considered a delicacy in China and Hong Kong, and also the spines of the pangolin are used in Chinese medicine. So these have been hunted and are on the endangered species, but they're also illegally traded in the marketplaces in China. So this outbreak started in Wuhan City in China in December of 2019. And since then, it has spread widely globally. And as of information yesterday from the CDC, there were 84 countries reported. Actually, this morning, the WHO put out their situation report, and they have 85. And as you look at the information coming from the Centers for Disease Control, the World Health Organization, or a map that Johns Hopkins puts out, there's a little bit different numbers on all of them, but they're pretty close. So the World Health Organization declared an emergency, a public health emergency, on January 30th of 2020, and the next day, the U.S. declared a public health emergency. And we're beginning to see now that this virus is continuing to spread. So this is a map from the Centers for Disease Control, and it's, as of yesterday, it shows you all of the locations in the world where this virus, where cases are reported. This is not where there's sustained transmission, but just cases reported. And if you don't like looking at maps, if you want to look at names of countries, here are the names of the countries. And in bold are the World Health Organization areas of the world, so Africa, Americas, Eastern Mediterranean, Europe, Southeast Asia, and the West Pacific. And I think you can see that this virus is occurring in all of those areas. Sorry, let's go back one. What's the difference between there being cases and this being considered a pandemic? Well, the pandemic is declared when there's sustained transmission in multiple of these areas. And so far, there have been cases reported everywhere, but not necessarily sustained transmission. But that may be yet to come. This is the map from the World Health Organization. And what I like about this map is the size of the bubble gives you a little bit of an idea of how many cases you're talking about. But it only goes up to 5,000. So China's bubble is pretty small because they've already had 5,000 cases long ago. But you can see that this virus has really been very affected at entering all of the globe, and it's because we really have become a world where people do tons of travel. So if we think about this virus, this is a rapidly evolving epidemic, and it's important to look at what the cases have been. So this is a report published from JAMA, and it's from the Chinese CDC, or the equivalent in China of our CDC. And this described the cases in China. So of the cases in China, 80% of cases were considered mild, 14% severe, and 5% critical. Critical meaning there was organ failure. So intubation was required, and then kidney failure and other things evolved. Remember, it's important to know that some infected people remain well. And almost all of the cases are in adults. Only 2% of the cases in China were in children. So 1% in children under a year of age, or under 9 years of age rather, and 1% in children 9 to 18. All the rest of the cases were in adults. The symptoms, fever, cough, and shortness of breath, very nonspecific. This looks like almost any other viral illness, but it can progress to pretty severe pneumonia. The illness is clearly more severe in those who have underlying chronic diseases, and the overall fatality rate is reported in this study to be 2.3%, but it varied by age. If you looked at people over 70, or in their 70s rather, there was an 8% fatality rate. And if you looked at people over age 80, almost 15% mortality rate. In some studies, if you look at patients with underlying chronic illness, the rates go up even higher. So a disease that certainly is scary, but remember that overall case fatality rate is probably in reality much lower than that, because remember that people with mild illness are not going to seek medical care even, and they're not going to be counted in the numbers. So it's probably a much lower case fatality rate. Now, this is the information as of yesterday, and I actually have the updated numbers for today. Within China, there have been 80,422 cases, and actually as of today, it's 80,565 cases. Of those, 143 are new, so that's a little bit higher than yesterday's 120, but not super high. And the total number of deaths is now up to 3,015, and that would give them a case fatality rate of 3.7%. Outside of China, there is now much more rapid spread or increase in the numbers, but of course, you know, the amount of space there is outside of China is much bigger than even China. So outside of China, there are 12,668 cases confirmed. Of those, 2,103 are new. So it's only been within about the last 5 or 6 days that there have been more new cases outside of China than within China. And of these cases outside China, 214 have died for a fatality rate of 1.7%. Now, if we go to the cases in the U.S., I'm giving you the official numbers from the CDC website and also the numbers from the Red Book Online, but these are changing numbers. And depending whether you look at Google or TV or, you know, listen to a news report, you may get different numbers. But the CDC site, as of yesterday, had 99 total cases. These include confirmed cases at the CDC and presumptive cases from the states. There were 10 deaths, which makes a fatality rate of 10%, clearly probably because we're recognizing the disease in the sicker patients. And 13 cases have reported diseases. If you happen to look at this morning's New York Times, there's actually a map that they provide that shows you where the cases are, and the most cases are actually in Washington State, where there was an outbreak in a extended care home. The Red Book Online numbers from yesterday were 149 cases in the U.S., 11 deaths, which would be a fatality rate of 7.4%. And then remember, in addition to the cases in travelers and the person-to-person spread, there have been cases in people who have been repatriated. So there were 3 people who lived in China who came back and developed their illness while here. Almost certainly they got it in China, and 46 cases from the cruise ship. Within New Jersey and New York, this is from the local news, so I don't have these confirmed, but there are 2 cases in northern New Jersey, none in Monmouth or Ocean County, by the way, and there are 22 cases across New York State, and that actually, as of today, is up to 23 cases. And as you know, one of those cases is in New York, or several of those cases are in New York City. So this virus is very efficiently spread from person to person. And as it has a lower fatality rate, I think it's very likely that we're going to continue to see spread of the virus. But remember, 80% of the cases are going to be mild cases. Unfortunately, in people who are older or have underlying disease, these may not be such mild illnesses. The incubation period appears to be 2 to 14 days. There's been some discussion that perhaps it may be longer in some patients, but generally it's considered 2 to 14 days. The spread is by respiratory droplets. There is not evidence that this is truly airborne. These are droplets, and we know for diseases that are spread by droplets, so that's like respiratory syncytial virus or influenza, those droplets fall to the ground within 3 to 6 feet. So if I'm coughing or sneezing, my droplets from my sneeze travel only about 3 feet and at most 6 feet. So that if you stay away more than 3 to 6 feet from people, you're not going to be exposed to the droplets. Now we have a ton of unknowns. One of the biggest unknowns is, are asymptomatic patients contagious? We just began to realize that there are asymptomatic patients. We know, and that's determined by them having a virus detected by PCR in their noses. We don't know if they are contagious or not contagious. We don't know how long a person is contagious or when they start being contagious. For most viral infections, you're most contagious when you begin to have symptoms. We don't know that for sure about this virus. We do know that people who have gotten the virus, gotten sick, been hospitalized, and recovered, their PCRs are still positive. So there is still viral material in their nose and throat. But we don't know if they're still contagious. So simply finding a positive PCR doesn't tell you about the viral load or how likely they are to be contagious, but it certainly makes us a little bit nervous about knowing when these people really could return to work or return to the public. And then there's a big, huge unknown is what the role of children is. Certainly children get lots of the regular non-novel coronaviruses. There's not a lot of evidence that they transmit it to adults. And for these novel viruses, children have really not been big players in the outbreaks. So I think we're waiting to hear that. One of the other things that I should have mentioned when I was talking about the outbreak in China that was described is not only is the disease occurring in lots and lots of people, but there were 1,716 healthcare workers who were involved and who were reported in that JAMA article, and of those, there were 5 deaths. So this clearly is a risk to healthcare providers. We need to be sure that we do use protective equipment to protect ourselves. So how do you make the diagnosis? Well, the diagnosis is made by these polymerase chain reaction testing. And right now, the confirmatory test is still done at the CDC. The test is not yet commercially available, but it appears that it will be commercially available very soon. And I don't know if this is good news or bad news, but there will definitely be more testing done soon. There are test kits being developed at both Rutgers and Hackensack. Neither are approved yet for use, but it's thought that both of those will be approved in the near future, as well as a commercial lab, LabCorp, will likely have the test soon. The New Jersey Department of Health does have the test kits available, and they are running the test twice a day. It takes about 6 hours to get the test result, but I think this is very important for people to understand that the New Jersey Health Department's not just testing anyone who wants to be tested. The patient has to meet certain criteria before they can be tested, and the testing has to be approved by both the local health department and the New Jersey State Department of Health. And in order to submit specimens, you have to fill out the COVID-19 patient under investigation short form. So you can't just write a script for your patient or send them to the ED and say, please test them. They have to fit these criteria. And here's the next page, which gives you the criteria. And you'll notice on the bottom of the slides, there are the websites where you can get this information. So, and again, this is as of this day in March 2020. This could change tomorrow. So currently, the New Jersey Department of Health will only test you if you have clinical features and an epidemiologic risk. So fever, signs of lower respiratory illness, okay? And either you know you've been close to somebody with confirmed COVID disease, or you have a history of travel to those 5 countries that are the high-risk countries. So that is China, South Korea, Iran, Italy, and Japan. So those are, for New Jersey Department of Health, you need to have, right now, you need to have that scenario. The only place where you don't need an epidemiologic risk is if you have a patient with severe acute lower respiratory illness, like adult respiratory distress syndrome. They're in the hospital and you don't have another alternate explanation. Those people can be tested even without an epidemiologic risk. Now, close contact by the New Jersey Department of Health is defined as being within 6 feet of a case for a prolonged period of time. I think this is very important because I've gotten several calls from people who are concerned that maybe they walk through a mall or they walk through an airport. Could they have possibly been exposed? It really does need to be close exposure within 6 feet for a prolonged period of time. And that could occur if you're caring for, living with, visiting, or sharing a healthcare waiting area or a room if you're an inpatient. So healthcare waiting area, again, you'd have to be within 6 feet. So hopefully we pull all the EDs to full so that we don't have a lot of people in the waiting rooms being in direct contact. And then the other definition of close contact is if you have direct contact with infectious secretions of a COVID case. So you're a healthcare provider and you were coughed on, or your family member and you were coughed on. Those would be the scenario for close contact. Okay, so that's the diagnosis. I did want to say one more word about diagnosis before we go on. So I was listening to NPR this morning, and they were saying that in New York City, all you need is a doctor's note that says you need to be tested. That is not the case in New Jersey. So in New Jersey, you have to meet this criteria. So NPR, in my opinion, usually gets it right, and they may have gotten it right for New York, but it is not true for New Jersey. And then one other thing I wanted to comment about was what clinical specimen are you supposed to collect and what should be sent? So the clinical specimens are 2 specimens from the upper respiratory tract, and that should be a nasopharyngeal swab and an oral swab. And those are collected on fiber synthetic fiber swabs with plastic shafts, okay? You're not supposed to use a wooden shaft because that can inhibit some of the viruses. And then you put that into transport media, and then a lower respiratory tract culture. So that would be sputum, bronchoalveolar lavage, or a tracheal aspirate. So they want all of those three things, and they should all be collected together and sent to the New Jersey Department of Health. And if you go to that website below, you can get the information on exactly how it's transported. Okay, let's get to treatment. So right now, the treatment is really mainly supportive. Many mild cases will not really require hospitalization, but any case needs to be isolated. So the mild cases potentially could be diagnosed and then sent home to self-isolate. As you all can imagine, that's dicey in this country. It's hard for people to stay at home. And remember, you're not only staying at home, but you're staying in a room and trying not to expose your other family members. So clearly not an easy deal. And again, we don't know how long a patient continues to be contagious. There are drug trials in progress. The one that you've probably heard about the most is the remdesivir, I think I'm pronouncing it correctly. This is a new antiviral that was actually developed to treat Ebola virus, and it's now being tested in the coronavirus. It is available in the U.S. In order to use it, you have to get an investigational new drug application. You have to fill that out. So you have to fill out the IND and then request that the company send the drug to you, and there's all kinds of paperwork that entails. But it is available here in New Jersey. You just have to fill out the paperwork and get the okay for you to get the IND. Clearly, right now, this treatment is being reserved for patients who have severe disease, critical disease. We don't know if early treatment would be better. Likely it would be, but we just don't have very much information on it yet. There are also a variety of other antivirals that are being tested, including just the influenza antivirals, oseltamivir, and then several of the antiretrovirus drugs are being tested. But again, none of them are licensed for use, and there really isn't good information on any of these antivirals yet. But what about prevention? So I get a lot of questions about travel, and I'm sure all of you are getting lots of questions about travel. So avoiding travel outside the country certainly is one way to prevent disease. And the Centers for Disease Control puts out these travel notices, and they update the website literally every day. So right now, there are 5 countries that have either level 3 or level 2 alerts. So a level 3 warning means that there is widespread sustained transmission within those countries. And essentially the CDC says if there's widespread sustained transmission, you should avoid all non-essential travel. So they've divided this into 2. So China and Iran are listed separately because for both those countries, there are U.S. entry restrictions. So if you are not a U.S. citizen and you're traveling, you're trying to enter from China or Iran, you will be restricted currently. The other 2 countries that have level 3 warnings, that's avoid all non-essential travel, are South Korea and Italy. So again, in both those countries, widespread sustained transmission, but there are not yet any U.S. entry restrictions. And then finally, there's a level 2 alert. In Japan, there is sustained community transmission, but it's not widespread. So that's a lower alert level, and the recommendation by the Centers for Disease Control and Prevention is that older adults and chronically ill should consider postponing non-essential travel. So think before you go to Japan. The Centers for Disease Control and Prevention also put out a recommendation that cruises to Asia should be avoided. So I think most of the cruise companies have already stopped doing that anyway. There were several countries who used to be on the watch, or where there was limited community transmission, but as of March 4th, and I checked it again today, there are none currently listed in the watch category. So in the past, there were several other countries on there, including Hong Kong, Taiwan, I can't remember the others, but they are currently taken off of this list. Well, what else can you do if you're not a traveler? And by the way, you know, that travel is for international travel. I think the bigger question now is, what do you do about U.S. travel? And the answers are, at the moment, I don't think you need to cancel your plans, but there are many meetings that are being canceled. There are many medical meetings that are being canceled because of the concern that this epidemic is going to increase within the United States. And I think, you know, it depends. I'm not so much worried about children because, again, they don't seem to be affected. But if you have a chronic illness, you really should think twice. You don't want to be in big crowds. Airports inevitably have big crowds. So there are vaccines that are in development. Most people think it'll take at least a year to come up with a vaccine. It's possible we could have a vaccine before that. If you do develop COVID-19 disease, then you should seek care, but you should call the hospital or your healthcare provider first to let them know that you're concerned that you have this or that you've been diagnosed, and you should follow whatever isolation procedures there are. So I would think for most people in practice, if you get a call from a patient saying they have COVID, you're probably not going to have them come to your practice. You're probably going to refer them to an emergency room, but make sure they actually need care before you just refer them. And remember, it doesn't make sense to refer people to the emergency room to be tested unless they fit that criteria for New Jersey. So just because someone's concerned, a parent's concerned, do not send them for testing. We don't have the kits. The hospital has to get the okay of the local health department and the New Jersey department, and they have to fit that criteria that I outlined before. So if you've been exposed to patients, or if you've traveled to China or areas with sustained transmission, then the recommendation is either for self-imposed quarantine or the country will impose quarantine on you. And currently that quarantine is for 14 days. When you're in self-quarantine, you are not supposed to go out in public, and you should keep 6 feet away from your household members to protect them. What's good advice for everyone? Clearly, hand washing is important. Soap and water is best. If you don't have soap and water, you can use the alcohol stuff. Cough hygiene, cough into your elbow, cough into your sleeve. Now that we're all doing cough hygiene, I'm not sure if we want to be bumping elbows as our new form of greeting. And this is a really important one. Stay home when you're sick. Please don't come to work. Don't go to your office if you're sick, because you run the risk that you may transmit this to your patients. So use the protective equipment appropriately. Masks and goggles are what's recommended when you're seeing a patient with cough, and that's not only for those who have COVID-19, but even for patients with influenza. We're supposed to be wearing masks, and it's even better if you either wear glasses or if you have shields, face shields to protect you. And then finally, there's this idea of social distancing. So if you stay 6 feet away from everyone else, then you will be protecting yourselves. Obviously, that's not possible with our jobs. We're going to be up close and near to our patients. But remember, if you have a patient who's symptomatic, put a mask on to really try to protect yourself. I think we're going to see a lot of mandated social distancing. So there's going to be not only closure of a lot of medical meetings, but there probably will be sporting events that may be considered, lots of gathering that may not happen. In China, one of the things they did was they really stopped all travel. They stopped all of the New Year's celebration. This virus really popped up at a time that was kind of an amazing time. So it started in December. The Chinese New Year is actually starts in January 25th to February 8th. This year was the Chinese New Year. So this epidemic started just before that. And in the Chinese culture, it's expected that you'll travel to your family home. So January is the time of massive travel across China. And that really explains why it got such a hold and such wide transmission within a very short period of time. So within China, they did not have a lot of the celebrations that were planned, and they tried very hard to limit the spread. And it does appear that their numbers are dropping dramatically. But we're just beginning to see this epidemic here, and I think it will take a while before we get some control. I want to finish with these resources. There's a New Jersey state hotline. I'm putting up the number for you. Unfortunately, it does tell pretty much anybody who's worried to go to an emergency department. Again, if you don't have an epidemiologic link in New Jersey, you're probably not going to be tested. But of course, if you're sick, you may need to go to seek health care. These are the websites that I showed you before, but I've also included on here the New Jersey government website, and it's the one that's got all of the details on how you submit specimens. And then that Red Book online, for all of you who have the Red Book, check it out. This was just updated yesterday, and it's really a very nice small chapter on COVID-19. And I think that is pretty much what I have to say. This is another very contagious condition that is smiling, and one of the contagious things that we don't want to stop. So at that point, I'm now ready to take questions with the caveat that I'm probably not going to have answers to most of your questions. And the answers I give you, for the most part, will be my opinion, certainly not the opinion of the New Jersey chapter of the AAP, and not the opinion of the national AAP. So I'll give that disclosure.
Thank you, Dr. Fisher. So we have a number of questions here, some of which I believe have been answered throughout your presentation. And so I will move over those. Charlene is also helping me on this one. For the audience, if we've missed one of your questions, please let us know that in the chat box, and if we have time, we'll address it here. If not, again, we'll put together those answers and distribute those out at a later time. So Dr. Fisher, the first question I have is, do you feel that elective surgeries, such as an example, cataract surgery, to be postponed as a result of the coronavirus?
So I think at this point, I would say no, but with a caveat. Certainly, if this is a person who had recently traveled to one of those 5 countries where there's sustained transmission, or you knew you had contact with one of those travelers, or you were worried, then yeah, I would postpone the surgery. But if you've had no exposure, then I think you're okay to go ahead with elective surgery. So only the people who had an epidemiologic link would I say postpone elective surgery.
Charlene.
Got another one?
Someone asked, we have students in Mexico coming back on Monday. Should they be quarantined for any period of time?
So the recommendation on quarantine is only from those 5 countries. So only from China, Iran, Italy, Japan, did I get them all? And South Korea. So Mexico, although there has been a case in Mexico, it does not mean just because there's been one case reported in the country that we need to quarantine people. So I would say for Mexico, the answer is no. Clearly, if they get sick within the next 2 weeks, they should quarantine themselves. But remember, I'm not so much worried about students, at least the pediatric students, because they really have not been a huge part of this outbreak.
Okay, so do you have any thoughts or recommendations on the effectiveness of benzalkonium chloride that found in the alcohol-free hand sanitizers being widely used in schools?
So the hand sanitizers, you know, the ones that have alcohol in them, you know, we know for sure that they work, but I would say the other ones are hand sanitizers, and they probably do work. When in doubt, soap and water is always fine. Soap and water doesn't necessarily kill the virus, but it washes it off, which is what you're trying to do. So I'm okay with the hand sanitizers. I would say within schools, if that's what you have, you don't need to switch to an alcohol-based hand sanitizer. One of the problems of having alcohol-based sanitizers in high schools is that children tend to drink them. So, you know, let's not put our kids at risk because of something we're worried about. Soap and water will also work just fine.
Can you discuss the sensitivity and specificity of the tests?
I would love to, but I have no idea. In general, the polymerase chain reaction tests are very sensitive and highly specific, but I have not seen any numbers for false positives. And, you know, the biggest problem with false negatives would be either the timing of the specimen or the quality of the specimen. If you swab the tongue, you may get a false negative. But as far as cross reactions and other things that might cause false positives, I just haven't seen any information. Do I think there probably is or are? Absolutely. We know that the original kits that were shipped out to states did not perform very well, so that they were taken away. The CDC has been criticized for not sending the kits out fast enough. You know, these are brand new kits. You have to make sure they work before you send them out, because exactly what you don't want are a lot of false positives or false negatives. So that's another one that I just haven't seen any information on, so I can't give you a better answer.
Thank you. So next question is, do you have any advice on how to prevent the spread in a pediatric office that does not have a negative pressure room?
So again, because this is droplet spread, you really shouldn't need a negative pressure room. You know, those are recommended as quote unquote ideally, but even within hospitals, we don't have enough of the negative respiratory rooms. So what's recommended is that you just close the door. If you have a patient who you think has disease, that you simply put a mask on the patient and close the door. And then you transport them to wherever the diagnosis can be made, or hopefully eventually we'll have a setup where you could actually get the specimens yourself and transmit them. The routine cleaning that you do in your office, or that you should be doing in your office, as far as, you know, wiping things down, should be enough to kill this virus. It is a fairly hardy virus, so if you don't wipe down your office, it can potentially stay on a surface. But the recommendation for the coughing patient is put a mask on the patient and put them in a room. When you go to examine them, it makes perfect sense for you to have a mask on yourself as well. And certainly if you're taking any specimens, you should be sure that you're wearing masks, and gowns and gloves are recommended, and also the eye protection.
Do you have any comments on reports from China about using chloroquine as treatment?
I don't know anything about chloroquine as treatment. I haven't seen those reports, and I just don't know anything about it. So sorry about that one.
Might you have any thoughts on precautions needed to be done by schools with special needs students, such as the autism population, especially if one student had coming back from Disneyland in California on Monday?
So I think that the usual precautions that you do during influenza season would be, if you do something similar to that, I would say that's what you need to do. The concern, of course, is that certain children with developmental disabilities or patients who have children with chronic illness may be at higher risk. Although we didn't see that in China, maybe it just wasn't reported specifically. Certainly we know that neonates, actually there are some neonatal cases, and they have had mild illness. So it's I'm pretty happy that the children do not appear to be severely impacted by this virus. Will there be exceptions? Absolutely. Will there be panic because people are coming back from travel here, there, or anywhere? You know, I think we've already seen that. But I think that the usual precautions you take during influenza season really should take care of this virus as well.
Will surgical masks be appropriate for healthcare workers to assess patients rather than the N95, since primary care physicians either have no access to N95?
Absolutely. So although the N95s are recommended, they're already in very short supply. In many hospitals, they're already being locked away so that they're not, so that they don't leave the premises in people's backpacks, but also so that they're not overused. Again, because these are droplets, the mask, the regular surgical mask will give you some protection. But as for any of us who have been fit tested, you know that the protection you get from an N95 it's just a lot firmer seal. So there's a better chance that when you turn your head, someone can't cough into the space that's left with a regular surgical mask. But yeah, those masks will help you. And, you know, we were always supposed to be using them for personal protection. I think very few people do, but we probably would get less RSV and less influenza if we used them a little bit more carefully. I would say especially when people are doing cultures or, you know, getting those rapid strep tests that you don't always need, you know, think about whether or not you should have a mask on for the person who's getting those specimens.
Okay, next up is some private physicians do not have any PPE in their offices. Do you have any guidance on how to assess patients without droplet precautions to protect the practitioners?
So, you know, it's always been recommended that we have PPE in offices. So there aren't recommendations for what to do if you don't have it. You know, you're going to be assessing them from 6 feet away, which is not really a very good assessment. So I would say try to get some PPE for your office.
How can parents be reassured regarding their concerns with the virus?
That's a, you know, that's a totally unanswerable question. Some parents will certainly be reassured when you explain to them that overall 80% of people have mild disease, and this disease does not appear to be a major problem for children. Other people are never going to be reassured because they're concerned about every little thing about their child. So I think the techniques that you generally have used, and certainly those of us here in Monmouth and Ocean County, the kind of things that you told people when there were measles outbreaks and the kinds of things you tell people when influenza is going crazy, you know your patients well. There's not a one-size-fits-all. What will calm one parent will make another parent go crazy. So I think the medical home is really a wonderful thing because you all get to know your patients and you know how to talk to them and how to communicate with them and how to listen to them so that you really can try to calm their fears when they're inappropriate or get them help when their fears are appropriate.
Okay, here's an update that one of the attendees provided. I haven't confirmed this, but LabCorp has the capability to test as of yesterday and Quest as of this coming Monday. It was announced on both their websites yesterday and in a press release.
Fantastic. That's thank you, whoever sent that in. Thank you very much. I think what we don't know is what the cost of those tests will be. There is no cost for the testing at the New Jersey Department of Health, but of course there's the charge of the emergency department or whoever the office visit to get the specimens. But that's great news to know, and certainly, you know, it will increase the number of tests that can be done. Now there's going to be unanticipated downsides to that, I'm sure. again, because we don't know the number of false positives and false negatives. So we'll see what happens. Again, it's, as I said at the start, it's already out of date, you know, before I even open my mouth.
Okay, so here's the next one is, do you have any recommendations for protecting a newborn with people wanting to visit?
So it would be no different for this virus than any other virus. You know, people who visit should feel well and be immunized. So just as it's perfectly appropriate for you to say nobody can visit my newborn unless they've had a recent Tdap and unless they've been immunized against influenza. I think you should also have always been saying, please don't visit my newborn if you're sick or if you're unwell.
Does the virus live on surfaces, and if so, how long?
Yes, it lives on surfaces, and the exact timing, I think it's actually hours. Now remember, if you put it on a surface and then you put it in a dark area and, you know, play nice background music, it may survive longer than if you're in an area where there's light, either natural light or UV light. UV light kills viruses, and drying this, and when they dries out, it also makes it more likely to be killed. So it varies, but it definitely is hours. I'm not sure that it's days. And I'm just not sure. I don't have a definite answer for you there.
Next up is, if a suspected case comes into the office, how do we handle the expected exposure to everyone else?
So you call your local health department immediately, just as you as you would have if there were any kind of Ebola patient or measles, and just as you did when there were measles patients that came to your office. And then you let the health department decide about tracking and what you're going to do with the potentially exposed people. There have been, it really has been nicely reported all over the news and the radio that if you think you have this disease, you should call ahead before you come to the office or whatever. So what you're hoping is that you either get that call ahead and you can find out what their real symptoms are and whether they actually need to come at all, and you could send them to in some cases, send them to a more appropriate case. But that's all the literature that comes from the CDC and the New Jersey Department of Health says, please call ahead if you're going to visit a healthcare worker and you think you may have this virus. I think as the virus spreads, that's going to be less useful.
Is there a way to distinguish COVID-19 illness from the flu clinically?
No. That's a quick answer.
Next one up is, how much more severely are people affected by coronavirus if they are being treated with immunosuppression medication for a chronic condition?
The most we know is that people with chronic conditions clearly have higher fatality rates, but we don't have the details for what if you're on steroids, or what if you're on biologics, or what if you're on, you know, other immune-altering substances. So I think we just don't know the answer to that.
If a patient tests positive for the flu, is it safe to presume that COVID-19 is unlikely? Assuming they also have no epidemiologic contacts, absolutely. If there's also a contact, I would still say, I would feel pretty comfortable saying, I would feel very comfortable saying, look, this is influenza. You know, there'd have to be some other reason for me to think that I was being misled by the positive influenza test. And I just want to remind people that the influenza tests vary in their sensitivity and specificity. So the rapid point of care testing for influenza are sometimes only about 50% sensitive, so you're going to miss half the cases. The respiratory panels, the PCR tests, have a much higher sensitivity, more like 90–95%, provided you get a decent specimen.
Next one up is asking you if we have workers who go on vacation and travel to countries other than the 5 that you had mentioned earlier in the presentation, but take a cruise, is it necessary to self-quarantine?
So it depends where you're cruising. Certainly if you're cruising to Asia, I think the recommendation is that you're going to have to self-quarantine. If you look at some of those maps and see what's happening in Europe, well, you're not cruising in Europe, likely, but you know there's more and more disease right now. The Caribbean looks like the place to go, but that could change. That could change quickly. So I think it really depends on where the cruise goes and what happens over the next few weeks. And remember that CDC site is updated regularly. So a week ago there were 10 countries on there. Now we're down to 5. So I suspect that it'll go up before it completely goes down.
Are there any concerns about clothes or products being shipped from China?
No.
Okay, so I have one last question here that I'll ask, and then we'll move on here. And again, to those of you that are attending, if you felt like your question wasn't answered, you can forward an email to us at, you can use mine, which is mweinstein@njaap.org, and we'll secure those answers and get them moving on to you. Again, mweinstein@njaap.org. Last one is from a school nurse. She said, we ordered rubber bracelets to support a student with leukemia and received them a week ago. They came from China. I want to confirm that these bracelets are safe to distribute. The teacher is reluctant to even open the box.
Yes, they are safe to contribute, and thank you for supporting kids with chronic illness.
Okay, so we could go on with this for quite a while, and time is running short. So I just have a couple pieces of information that I want to share with everyone. First of all, before there will be an update to this webinar that will be offered in the near future. The exact date will be dictated by the developing circumstances. When that date has been established, a notice will be distributed indicating the date, time, and also include a link to registering for that update. Today's webinar, as you all know, was free of charge. However, it hindered our ability to fully accommodate the extraordinarily high number of interested attendees. To avoid this in the future, we hope you will consider making a donation today. The information on how to do that is located in your chat box now that Jake will be sending out. And this will not only help us to defray some of the costs of today, but it'll also help us to better ensure access to future updates to the COVID-19 webinar. And there will be a nominal fee attached to that to register. And that will be in the information that we send out. So on behalf of Dr. Fisher and the NJAAP, I'd like to thank everyone today who has joined us, taken time out. Also on behalf of all of us who attended this information that was put together by Dr. Fisher, thank you, Dr. Fisher. It is just a terrific resource that we have, and so you have the thanks of all of us for doing what it is that you do for us. So with that,
Michael, do you want to mention that we may do a repeat, or did you already say that and I was zoned out?
So no, thank you, Dr. Fisher. At 2 o'clock today, this webinar will be available on the NJAAP website. And that will go for the many people that we've heard from who were not able to register for this webinar. So the recorded webinar will be available. It's how long that's going to remain on the site is going to be, of course, dictated by how rapidly situation changes. And we will take our guidance from from Dr. Fisher on that. Whether that shelf life is 2 days or 2 weeks is yet to be seen. But once we have a feel for that, then of course we will be updating the webinar itself and making that notice. But that'll all be available on the homepage of the njaap.org website. So with that all completed, this concludes our webinar.